Hello, my name is Dr. Rob Page and welcome to Doc Talk. Doc Talk is a podcast that is produced by the Knoxville Academy of Medicine and features its physician members giving information to patients that is helpful in terms of making their healthcare decisions. And I feel fortunate to have with me today Dr. David Harris. Dr. Harris is an ophthalmologist who works with university eye specialists, and his area of expertise is the cornea. Welcome to Doc Talk.
Thank you.
First question, in terms of we're talking about eye diseases and different parts of the eye. What part of the eye is the cornea?
The cornea is the very front part of the eye. It's like the watch glass of your watch. You don't actually see the cornea when you look at someone's eye. You see their eyes blue. You're looking through their cornea at their iris. The cornea is clear in normal circumstances, and most of what I deal with in taking care of patients with corneal problems is the cornea has become cloudy.
Now, we talked about another issue that you run into with patients who have corneal diseases, and that is keratoconus. Can you tell us what keratoconus means and maybe some of the symptoms that would be associated with it?
Sure. First of all, the normal cornea has a very round, smooth shape like a baseball, and that's necessary to get clear vision either with or without glasses. In keratoconus, the cornea becomes misshapen and it doesn't form a shape that can be easily corrected with glasses, and the cornea protrudes, it gets thinner, and in later stages it may get cloudy. But even when it's clear, the shape of it is so abnormal that glasses will no longer correct vision. For some period of time, a contact lens that covers up the abnormal cornea can improve vision for patients with keratoconus. And then finally, if the cornea gets too cloudy or too misshapen, we have to replace the cornea with a corneal transplant. Keratoconus is not super common. It occurs in maybe 1 in 4,000 people, but in a city the size of Knoxville, there's quite a few people with keratoconus.
Now, are there any risk factors that are associated with keratoconus or any behaviors that are associated with it?
Yeah, that's a good question. Most of the time, no. Most patients with keratoconus have it for no reason, but there are certain groups of patients that are at increased risk, specifically patients who have conditions, either physical or psychological, that make them rub their eyes a lot. So if you have atopic disease, which makes itching a big part of your life and you rub your eyes a lot from that, those patients are more likely to get keratoconus. On the other hand, as I said, a majority of patients that I see with keratoconus have no known risk factors. It's just bad luck. We don't really know what causes it, but we think it has to do with weakening of the proteins in the cornea, either naturally or produced by excessive rubbing.
Gotcha. Now, as a patient, if we all experience changes in our vision as we grow older, and there are other things, of course, that can cause sort of cloudy vision in the eye. What other symptoms would you be experiencing as a patient who has keratoconus, and under what circumstances, other than maybe seeing an optometrist, would you see an ophthalmologist to be evaluated for this?
The usual thing that brings a patient to my attention that has keratoconus is that they get blurred vision, and like most people, go see an optometrist or an ophthalmologist to get glasses. And at that examination, either the doctor is unable to correct their vision fully with glasses, or actually, in examining the eye, sees some of the early abnormalities of keratoconus. Very early on, when you look at an eye that has keratoconus, it looks pretty normal. So the usual thing is, hey, I can't correct my vision with glasses.
And you mentioned in the early stages that you can sometimes use a contact lens to actually correct the vision changes that are made by this. What other therapies are actually available to patients who have keratoconus?
I would say specifically, you're correct that a contact lens, usually a hard contact lens, is necessary to correct the earlier stages of keratoconus. It doesn't actually make the eye more healthy or make the cornea more normal. It simply covers over the abnormal curvature and replaces it with its own curvature. So it makes you see, but it does not affect the course of the disease. In the past, it was thought that maybe hard contacts actually slowed down the disease, but that's really never been shown to be true. So when a patient has the disease to the extent that they cannot be corrected with glasses, cannot be corrected with ordinary contacts, then there are special contacts, some of which are quite remarkable, that can take a patient that has very poor vision and allow them to see. Once the contact lens doesn't work, then we're looking at usually replacing the cornea surgically. There are some other treatments that can sometimes temporize. There's a procedure called placement of intacts, which are tiny curved pieces of plastic that are inserted directly into the cornea that sort of put it on stretch and may take out some of the abnormal curves temporarily. But ultimately, most of these patients that can't be corrected with contacts end up needing surgery.
So sort of like getting a facelift on your eyeball. You're stretching it, you're stretching it thinner and trying to straighten it out.
Exactly.
I'd also read somewhere here recently that there's a therapy that involves collagen cross-linking.
Right.
Is that something that's widely available, or is it useful?
It has become widely available. Basically, collagen cross-linking is the first treatment we've had to slow down and actually affect the course of the disease. Most people get keratoconus as teenagers, and it gets progressively worse over about a 20-year period, progressing through stages of needing a contact, then maybe needing a transplant eventually. Collagen cross-linking gets right at the thing I mentioned earlier, which is the weakness of the proteins in the cornea. Collagen cross-linking was developed in Germany 25 years ago. It took a long time to get approved in this country because of safety concerns. It was finally approved here in this country around 2016. And what this involves is soaking the cornea in a chemical which is really a vitamin, riboflavin, by putting a whole lot of drops in the eye over a 30-minute period, and then shining an ultraviolet light on the cornea. What this does, the combination of the vitamin and the ultraviolet light, is it makes those weak proteins in the cornea lock together so they don't stretch anymore. And it really has been proved over the course of its short existence, 25 years or so, to slow down or stop the progression of keratoconus. In general, it does not make you better. It does not make you see better than you were before you had it. But if it stops your disease at a point at which you can see with glasses, or stops your disease at a point at which you can see with a contact, it may make it possible for you to avoid having a corneal transplant.
So, but ultimately, a lot of patients end up getting a transplant. And that is a surgical procedure that you perform quite often.
Yeah.
What exactly does a transplant involve? As a patient, if I'm told that something like a transplant, certainly organ transplantation is becoming a lot more commonplace than it was 20 years ago. But what would something involve with a corneal transplant? Are there a lot of drugs involved that you have to take for a rejection, like we think about for solid organ transplants?
With corneas, fortunately, rejection is not nearly as big of a problem as it is with a vascularized organ like the kidney. We think it's because the cornea has no blood vessels, but there's probably more involved. But in general, we don't have to worry about it as much, but it does happen. If someone has a corneal transplant that is clear and 6 months later they begin to see halos or hazy vision, we worry that rejection may be starting. The good news is that when we catch those forms of rejection early, usually we can treat it with eye drops and clear it completely up. Wow. So rejection is uncommon enough that we don't need to put patients on the type of drugs that they need if they have a heart transplant or a kidney transplant. But we do put them on eye drops, and the eye drops early on prevent the onset of rejection, and then later, if they should get some rejection and we catch it early enough, we put them back on the eye drops and that can clear it up. There are many things that, besides rejection, that could affect the success of a transplant, but in keratoconus, the success rate for transplants is very high. Of all the diseases that I do corneal transplants on, keratoconus has the best prognosis. In other words, 95% of people who have a corneal transplant for keratoconus will have a successful transplant and have improved vision.
So if I'm a patient, been diagnosed with keratoconus, I need a corneal transplant. What would that involve for me as a patient in terms of what sort of preparations would need to be made? How long does the surgery generally take, and what would the recovery time be?
For the average person who has a transplant, the ultimate decision to have it actually comes with the patient. Basically, whenever their vision, with whatever we can do for them, is no longer adequate for their life, that's when they say, hey, it's time, I need to have surgery. And so it is important, as you have implied, that the patient know what's involved to make that decision so they can decide whether the cost or risks or other problems warrant are bad are at a stage where their eye disease warrants that kind of treatment. So say we've decided to go forward with a corneal transplant. What the usual situation is that we do that type of operation in a surgery center. It's a day operation, meaning you come in and you have it and you go home. There's not a lot of preparation for it on the patient's side. The patient will come into a surgery center. Usually, for most adult patients, they don't even have to be put to sleep. We give them some sedation and some local anesthetic around the eye, which doesn't hurt at all. So they're awake, but their eye doesn't feel anything. And the procedure usually takes anywhere from 30 minutes to an hour, depending on the type of transplant we're doing. And there are some variations on the types of transplants we do, depending on the type of disease the eye has. For most keratoconus patients, we do a type of transplant that minimizes the risk of rejection. And so when they come into the surgery center, usually the patient has to not eat or drink anything for about 8 hours before the procedure. We give them the local anesthesia. We do the procedure. They may stay around their surgery center for 30 minutes, but then they're ready to go because they've never really been down asleep. There are complications as with any operation, but 99% of the time the surgery goes smoothly, and most complications that can occur during surgery are correctable. And then afterwards, after the surgery, they simply wear a patch the first night and leave it on until I see them the next day. When I see them the next day, I ascertain whether the tiny stitches that are holding the transplant in place are all intact, that there's no leakage, there's no problem. And if as in most cases, everything looks good the next day, they don't have to wear a patch anymore. They will wear a shield, a metal or plastic shield over their eye at night to keep them from accidentally bumping the eye, because the eye is more fragile with being held in place by maybe 24 tiny sutures. These sutures are usually not able to be seen by the patient or anybody looking at the patient without magnification, and the patient doesn't feel them. But because the cornea has no blood vessels, it heals very slowly, and those stitches will stay in there for about a year before I remove them, which is a painless treatment we do, again, about a year later.
Wow. So not much preparation involved beforehand. And you mentioned that they were a patch over it. So typically this is approached one eye at a time. This is not, and do patients with keratoconus, do they typically present with the disease in both eyes, and then you would over time have to operate on both?
Yeah, most patients with keratoconus have it in both eyes, but it's pretty frequent that there's a significant difference between the two eyes. I mean, one eye will be worse, one eye will be better. So there are a lot of patients that may have a transplant in one eye and never need it in the other. Or they may have a transplant in one eye and not need the other for 20 more years. After surgery, there's an eye drop regimen, most of which is directed toward reducing the risk of infection, which is rare but can be bad. So we worry about that in the first few days. And then after that, eye drops are taken for about 6 months, and the purpose of those drops is to reduce or eliminate the risk of rejection. So at the 6-month point, if everything's gone well, they can stop the eye drops. I still see them pretty frequently, about every 6 months for the first 3 years. We go over what to look out for in terms of rejection, because most rejection doesn't happen right away. It usually happens between 6 months and 2 years after surgery. So we talk with the patients about what to look out for, because I can't see them every day, but if they know when to call, when to report a problem, we get them in quickly to make sure that we can take care of that. In patients that do have rejection, we usually can clear it up with eye drops, but those patients, I may let them stay on eye drops long term, maybe 1 drop a day for years, because we feel there may be a little more risk of having again if they've had it once.
Gotcha. Now you talk about the risks of rejection afterwards. What about recurrence of keratoconus? Is this something that ever happens in a patient who's had it once?
It is extremely rare. We think the only time we really get recurrence of the disease is if for some strange reason the donored cornea came from a patient who was destined to get keratoconus, but nobody knew it. So when we look at corneas,
Bad luck, I guess,
yeah, when we look at corneas for transplantation, we look for signs of keratoconus. So we don't want to obviously remove the patient's cornea with keratoconus and give them a new cornea with keratoconus. So that's extremely rare. However, keratoconus affects the whole cornea, which is about 12 millimeters wide. We generally only replace the central 8 millimeters of the cornea. So there is some keratoconus that's still in the cornea left behind. And so this does not mean the disease comes back, but having that weaker cornea on the outside is like having a nice table with not so great table legs. So the table may slant a little bit. So over time, those patients may have some changes in their glasses prescription, but the disease doesn't come back. They're always generally able to be corrected with glasses. It's just they may have changes in their refraction over time.
Gotcha. So, well, you've given us some excellent information about keratoconus and about the incredibly advanced and easy procedures that are available to patients in this area. Dr. Harris, you're here with University Eye Specialists. You have offices that in the Knoxville area?
Yes, we have. My group has 5 offices, including 3 in Knoxville and 1 in Maryville and 1 in Morristown. Not all of the doctors in my group go to all places, but we have cornea specialists that go to 4 of the 5 places, so that to give increased convenience for patients. And our Morristown office is 50 miles northeast of here, which makes a shorter commute for patients that come and see us from the Tri-Cities and beyond.
Excellent. Now, do you have a website where patients who are interested about this disease, or who may have more questions about it, who can develop this, or is there a phone number they can call to maybe consult with you?
We have our website for our group. Some of the best information is actually available nationally at the National Keratoconus Foundation. It's an organization nationwide for support of patients with keratoconus, and they have extensive videos, written literature, way more than you would find on our website. But we are certainly we and our staff are certainly available to answer patients' questions.
We'll put that number down here at the bottom. So.
And most patients that have keratoconus that come to us usually have found out about it from an optometrist or another ophthalmologist, and those doctors will have referred them. So we don't see too many people who just look in the mirror, think they have keratoconus, and come in to get their keratoconus treated. Usually they're referred by a doctor. Most
excellent. Well, you've given us some wonderful information here today about an uncommon disease, but about a disease that's common enough in the Knoxville area that there are surgeons available, and surgeons available that are nearby that can provide treatment and provide the follow-up that's necessary in these instances. Dr. Harris, thank you so much for joining me here today.
Thank you for allowing me to. I'm happy to be able to present this information to the community at large, because particularly with cross-linking being a new and an exciting treatment that actually prevents the progression of the disease, we're now much more anxious to get these patients early when their vision is near normal, so they don't have to have some of the more complicated treatments later.
Most excellent. That concludes this episode of Doc Talk. Doc Talk is a podcast that's produced by the Knoxville Academy of Medicine, which features its physician members providing information to patients that is helpful in terms of making their healthcare decisions. I'm Dr. Rob Page, and thank you so much for joining us.